So for those that don't know me, I'm kind of loud here. I'm Ben Winston. I'm the last chief presentation this year, and I'm presenting my project, the utility of obtaining post-mobilization imaging in non-operative pelvic injuries. And my mentor for this project was Dr. Fries. Some background: pelvic injuries span a very wide spectrum of injury severity, ranging from low energy, very stable patterns that really require minimal, if any, active intervention, to the devastating high energy, unstable patterns with a very high rate of morbidity and mortality. We know that the pelvis can recoil to near anatomic alignment, so the deformation at the instant of injury is very likely much more significant than we see in the emergency room on static imaging, which really makes defining where along that spectrum your injury lies very challenging. But a missed, unstable injury can really be catastrophic. It can have debilitating chronic pain, leg length discrepancies, sexual dysfunction, or nerve palsy. So the prompt and accurate identification of these pelvic injuries is really critical as it guides the appropriate treatment recommendations. This study aimed to focus on the non-operative treatment of pelvic injuries that we believe are stable but carry the potential for occult instability. I think most of the people in the room are familiar with the Young and Burgess classification published in 1986, which was really an extension of the Penal-Tile 1980 paper that identifies stability based on static imaging in a directional force vector, the APC, or anterior posterior compression, and the lateral compression types, each of which have stable and unstable variants. The vertical shear, which is universally unstable, and the combined mechanism, which is basically to say it doesn't fit into any of the other categories there. But based on what you just mentioned, the utility of the static imaging has recently been called into question. Claude Saji et al. 2011 had an experimental protocol where they took all pelvic fractures to the operating room for static and dynamic radiographs. They found occult instability in 50% of the APC1s, about 40% of APC2s, 37% of the LC2s, which really highlights the difficulty in accurately defining the stability of these injuries based on the static imaging alone. It's also worth noting that they somewhat arbitrarily define instability as a displacement of greater than 1 centimeter. Whiting et al. 2017 demonstrate 100% negative predictive value of an exam under anesthesia, and people that have a negative exam under anesthesia can weight bear as tolerated. There, as already mentioned, there really is little research that exists concerning the clinically significant amount of displacement. And certainly, Dr. Saji's experimental protocol, while very thorough, is needlessly exposing many patients to anesthetic that may not be appropriate for an overall treatment strategy. The Orthopaedic Trauma Association recommends that pelvic injuries being treated non-operatively have post-mobilization films obtained to assess for occult instability that is not identified at the time of presentation. And that includes a series of 3 radiographs, an AP, an inlet, and an outlet view shown there. Mobilization can be defined, really it can be weight bearing as tolerated, it can be a limited weight bearing, it can be with a device, but the point is you get them up, walk them in some way, shape, or form, and then obtain those 3 radiographs to see if there's interval displacement. And this was the protocol that we were using for the 11 years prior to this study. And per literature review, is similar to other institutions' protocol as well. Interestingly, after we started this project at the OTA in 2016, Bice et al. Out of Utah presented an abstract, although their data is still unpublished as of Wednesday, when I last checked, that aimed to really answer the same question with a very, very similar protocol, and they concluded that routine post-mobilization films were really of low utility. Another thing to consider is that MRI has been proposed as a method to better define the ligamentous injury, but that appropriateness in clinical application really has not been defined. Regarding the costs, a 2011 study that looked at multiple trauma centers, cost of a routine pelvic x-ray, again, that's a single view, not the 3-view post-mobilization film, including the radius interpretation was $209 with a charged amount of $445. According to OHSU's billing department, we charge for a 3-view with interpretation $407. So there's obviously some range there that we're talking about. And if we look at these, if these are accurate, which they should be, ours is definitely less expensive than what they found in their study. The average amount of radiation from, again, a single view AP pelvis is about 60 to 75 millirem. And for reference, the background radiation is 300 to 600 millirem per year. And somewhat anecdotally, obtaining post-mobilization x-rays and awaiting a radiologist interpretation can delay the discharge, putting a further burden on both the patient and the healthcare system. So the question we aim to answer is how often does the review of these post-mobilization films change our plan from either non-operative to operative or change the weight-bearing status? And we hypothesized that the practice of obtaining post-mobilization radiographs on pelvic ring injuries that we had already deemed to be stable at presentation and are being treated non-operatively very rarely affects the treatment regimen and is probably not the most appropriate protocol. If this imaging is not being used to help guide treatment, it may not be and probably is not necessary, at least not routinely, and eliminating this step would definitely result in a lower cost and decreased patient exposure to radiation. And as mentioned, it's not been published if obtaining this imaging affects treatment recommendations. We obtained IRB approval in 2015, and we reviewed records from January 2007 through the end of 2014 as identified by the ICD-9 and CPT codes, which were really for all pelvic fractures. We excluded patients under the age of 18 and those with subacute or chronic injuries. And we underwent chart review and identified age, gender, injury mechanism, trauma activation status, and then recorded the initial treatment recommendations. Was this operative or non-operative, and what was our weight-bearing recommendation? For the non-operative patients, we checked to see how many of those had these post-mobilization films obtained within the 10-day period, and after those imaging, was there a change in our recommendations, either from non-operative to operative or a change in the weight-bearing recommendations. Any patients that were taken for an exam under anesthesia were considered operative, and of which there were 6. And periodically we did choose a random patients, collected data, and checked for accuracy, as a large amount of the data collection was done by medical students. We had 1,057 patients over the age of 18 that had pelvic ring injuries that we identified. 61% male with a mean age of 50, ranging from 18 to 103 years old. Most common mechanism of injury was motor vehicle collision. You can see the breakdown, and then the other category included things like being kicked by a horse or an assault, of which there were a handful. So there were 1129 total, but we had 72 that were under the age of 18. And really the key numbers are the post-mobilization films are obtained on 192 of the 402 patients, which is just under half, which we'll talk about. And there was a change in treatment plan, and in this case, it was from non-operative to operative in 3 patients. That represents 1.6% of those that had post-mobilization films. I think perhaps this is easier and simplified. 50% of the patients were presented as trauma activations. About 70% of those were male. 70% of trauma activations were treated operatively versus 53% of those that were non-trauma activations. And there was no incidence of failure treatment at the 6-week clinic follow-up, which was our limit for follow-up, was the 6-week mark, of which we had 63.7% of patients follow up. But those 3 patients, it's critical to note that for all 3 of them, it was explicitly noted in the chart notes that the decision to change from a non-operative plan to an operative plan was based on their complaint of pain with mobilization and not the imaging. So that is obviously very important, although there were 3 that did have a change. The first patient was a 34-year-old male, passenger in an MVC, not trauma activation, with a right-sided LC1 injury. There's the CT at the time of presentation. The post-mobilization imaging was read as no change by both the orthopedic team as well as the radiologist's formal read. And that is that imaging, which is pretty unimpressive. 5 days after injury, however, he had a right SI screw placed, and as mentioned, part of the documentation, this was for pain, not for imaging. There's a postoperative image. Second patient was a 21-year-old male intoxicated driver who struck a pole at an unknown speed. It was a level 2 trauma activation, diagnosed again with an LC1. Imaging at the time of presentation. Post-mobilization films were minimal displacement as interpreted by the orthopedic team as well as by the radiologist's formal read. And those are there. 3 days after, he had a left-sided PERC SI screw and a left-sided superior ramus screw placed. Also documented based on pain with mobilization. And the last patient was a 75-year-old male, fall from a 15-foot ladder, level 3 trauma activation, fell into that combined mechanism that we talked about. And on this one, we actually had plain films. We don't always have those. A lot of times the CT is what we get. And the measurement that you see there, 4.3, that's done by the radiology team. Post-mobilization films were showed by our notes. We read that as 5 millimeters of change, and the formal read from radiology was no significant change. There's the post-mobilization imaging. 6 days afterwards, underwent left-sided percutaneous SI screw across bilateral SI joints. And I've repeated it several times, but it's important. That was based on pain, not based on the imaging. So this has already been shown, the top part, but I think that is important. This number that I came up with, $78,000 over the period of the study, is based on what our billing office has given us as $407. But if you extrapolate out that based on this other study, they came up with $445 for a single view, it would potentially be a different, much larger number depending on which institution you're in, but that's the number we have for our institution. There's definitely some limitations to the study. There is no control group. This is designed as a descriptive study, not necessarily comparative. There is suboptimal follow-up with 63.7%, although we are specifically not looking at long-term follow-up. We're looking to see if we're using the information that we're obtaining, which is different. And actually 63.7% is not that bad when you look at trauma. When we look in the literature, it's somewhere between 31 and 87%. Probably the biggest issue, or I guess the biggest question that comes up is we only had about 50, just under 50% of patients with these non-operative pelvic ring injuries had these post-mobilization films obtained. And we won't know for certain why that is, but most likely is primarily due to attending discretion. There will certainly be some patients that were not able to ambulate within this 10-day time frame if they're intubated, if they have a brain injury, if they have bilateral lower extremity injuries that prevent them from getting up and mobilizing within that time frame, which is obviously not going to allow them to fit into this study. And then there's also presumed a group that has no pain with ambulation. We say, okay, just send them out, don't delay them. One thing that in retrospect I would like to look at is whether our behavior changed over the course of this study, whether when 11 years prior to this study we were doing this more consistently, and as we anecdotally noticed that we were not using the imaging, that tapered down. We didn't look at that, but I think that might be valuable to look at. So for conclusions, this is the first formal description quantifying the utility of routinely obtaining post-mobilization imaging. We did not have any incidents of failed non-operative treatment that was not clinically detectable by patients' reported pain, and in no case was there a change in the treatment plan based on the post-mobilization imaging. Therefore, we really recommend only getting this imaging when a patient is having pain. And in this data set, that wouldn't have changed any of the treatment pathways. And as a result of the study here, we have changed OHSU's policy, and we no longer routinely obtain this imaging. I just want to say thank you to Dr. Freese, Dr. Putnam, Chris Hart, Paxton Gelling, Minhaz, and Connor. Questions? Dr. Otlins?
Did you get a sense if surgery was helpful for these
I didn't look at that. That's a great question. Yeah, that's an excellent question. I'm kind of surprised I didn't get brought up before. That's an excellent question. I would have to look back. I think anecdotally, yes, if they're having pain with mobilization, and that's sort of presumed to be occult instability, that you're demonstrating dynamic instability, and so they're imparting surgical stability helps. But we did not look at those 3 patients. Dr. Ladd?
Yeah, thank you. Actually, your last point answered my big question, is anything changed? But delving into this a little further, did this start as a QI project?
It did not.
Because it, it breathes of that, and so it would be being a less harder on yourself because you don't have the follow-up, et cetera, et cetera. That's not the point. You wanted to change behavior, or if it were a QI project, you wanted to change behavior because you had a pain point. And so, and part of that question, is there any concern about standard of care? Does this disrupt the perceived standard of care as you must get a post-ambulation or a pre-ambulation x-ray?
So I don't think, so that is our protocol, or was our protocol. We were loosely following it. And it is used at some other places, as evidenced by a chart review, by a literature review, but that is not used by every place. So I don't think there is a defined standard of care. And the OTA recommendation seems to be you should do it, but not, certainly not followed to a T.
Well, and you pointed out, I mean, every single one that you showed that had surgery, you showed a CT scan. But we all know you can't see any of that on x-ray. So it begs the point, why would you bother anyway? Because you had to show the fracture on a CT scan, not an x-ray.
Right.
So in OHSU adapting this protocol, was there any concern about where that money went? So I'm
not to my
assuming
knowledge.
Radiology collects it, not orthopedics. So,
no.
But for your quality initiatives, and
Yeah.
maybe look how much we save the institution.
Yeah, that's a good question. No, I don't know where that. Well, although we came to these conclusions earlier this year, so that's a good question. I don't know where that money will go.
Well, congratulations. Nice study.
Thanks.